Hello, I'm Dr. Nagaraj Puttaswamy. Patients come to a surgical OPD commonly or very frequently with problems related to hemorrhoids, fistula or fissure. What are these conditions, or even sometimes pilonidal sinuses? These are common problems which any patients can go through. If there is a bout of constipation and the patient has to push hard stools, there may be small cracks on the anal orifice. These are called fissures. Unfortunately, these are very painful, and that may be presented alongside small amount of trickling of blood while the patient passes stools. This is commonly seen even from a small child to an adult, and it is easily managed medically. A simple fissure can easily be managed medically with the help of local ointment, and maybe we can supplement laxatives to those individuals, and sometimes a painkiller will be suggested. If this becomes a repeated activity, patient get into a state where it is called a chronic fissure in ano with anorectal sphincteric spasm. So recurrently this problem continues to happen. The patient has constipation and difficulties. Patient will not be relieved with medical condition or medical treatment. So where we subject the patient for a simple procedure called Lord's dilatation or anal dilatation along with the sphincterotomy, which can be done with the help of laser. Very simple outpatient procedure or maybe a daycare procedure. Next would be hemorrhoids. Hemorrhoids are generally called piles in common man's term. Hemorrhoids are normal cushions of vein which are normally otherwise there. They are dilated and they are become more fragile because of the high pressure in the venous channels. They may rupture and bleed. Most of the times hemorrhoidal bleeding is painless bleeding. So when compared to what a fissure would cause, it would be a painful small quantity of bleeding, where hemorrhoids will be a painless bleed. It will be a copious, significant amount of blood may happen. Many a times it is seen in patients who have portal hypertension, may be related to alcohol related or any other related, intra-abdominal pressure is high. Those patients will develop easily hemorrhoids. Those patients will present with significant amount of bleeding while passing stool. Many patients will come with significant high status of anemic status, meaning to say low hemoglobin status. Patients, I have seen patients collapsing in the toilet after the bout of huge amount of blood loss. So this is again a surgical procedure. If the patient comes very early in grade 1 or 2, we can easily treat them with medications. But if the patient have landed up in grade 3 or grade 4 surgical hemorrhoids, beyond that sometimes thrombosed hemorrhoid, gangrenous hemorrhoid can also happen. These are surgical procedures which we have to be performing on those individuals. What I usually practice is a stapler hemorrhoidectomy, which is very convenient. Again, a daycare procedure, a weekend procedure if it is performed. Generally, what everybody understands it, any procedure related to hemorrhoid is very painful. Following surgery, doctor would have shown hell on earth, is what the patient comes and try and tell. But definitely, related to stapler hemorrhoidectomy, I can definitely tell it has changed hell to heaven. The daycare activity or a 1 day's activity, we do stapler procedure, patient can recover, maybe go back to work on second or third day. That is a huge advantage when compared to any other conventional hemorrhoidectomy, or even whether it is Doppler-assisted or cryo or harmonic scalpel-assisted hemorrhoidectomy. All this, most of the times they become conventional type, but stapler scores very high over all these types of surgical procedure. Next would be common thing would be a fistula in ano. Fistula, otherwise terms as connecting between two surfaces. Two surfaces, one is skin and one is the buccal mucosa in case of fistula in the oral cavity. If a patient has cancer in the cheek, it can perforate and then it can show up from outside. There is a connection between the skin and the oral cavity. That is a fistula in the oral cavity. Similarly, a fistula can establish between the rectal mucosa to the skin around the anal canal. That is a fistula. It may be a direct fistula, a complex fistula, multiple fistulas would be there depending on what the cause would be. 90% of the times, all fistulas should be treated surgically. Medical fistulas are something like fistula related to tuberculosis or Crohn's disease. So they are most of the times multiple. They have to be treated medically because we have to treat the primary causes. If it is tubercular fistula, we put the patient on anti-tubercular treatment, or Crohn's disease fistulas, we have to treat them accordingly. Or fistulas related to cancer, we have to operate cancer. So generally a simple fistula following perianal abscess drainage or something like that, it is a simple fistulotomy or a fistulectomy can be done. A complex fistula with a fistula which has rose above the level of levatorinae muscle can be operated or treated with the help of one procedure called WAFT, VAFT, visually assisted fistulous tract ablation. We can use a telescope which we enter into the fistula's cavity, ablate from inside, close the internal opening and allow the external opening to close on its own. These are multiple ways of approach of fistula surgical procedures. I've been doing anorectal surgical procedure or proctology related surgical procedure for the past 25 years, 26 years, and I've done significant amount of all these procedures. I've been a mentor and a proctor for many of the young surgeons who have trained under me, and I've been proud to have been faculty in the companies where they manufacture staplers related to hemorrhoids, and I've done a lot of R&D related to this, and then I've given my inputs where the improvisations of the staplers have happened. Proud with whatever I've done till date. I've done justice to my patients who have come in pain or discomfort.